Thank you all for coming. As you gather, feel free to go through the line and grab yourself some lunch, and we'll be getting started with our program here in a few minutes. So feel free to get started with lunch.
to speak? We'll be starting in about 5 minutes, so do get your food and sit down. We plan to start at 12:15. Well, I'd like to welcome you all. It's 12:15. We're going to get started. And we're going to have a few recognition speeches from our supporting institutions to start with. And that will be from about 12:15 to 12:30, 12:35. And then we'll be moving into some CME. My first CME talk will be mine, which is of general interest for about half an hour. And we know a lot of you have things to go to, so at about 1 o'clock that might be a time if you've got other things to go to after my initial talk. And then from 1 to 2:30 we have 3 other talks that are continuing medical education that'll be a little more medically oriented. And you're all welcome to stay for all of that. I think you'll find it interesting, but we know some of you are busy, and if you have to get up and leave at any time, we understand that. We have a lovely alumni center here. We aren't able to quite fill it. It's just so beautiful, and it's just great that we have this. We're going to start our talks with our residency director. Brandon, would you like to come up and tell us what you have to say?
So I guess just first off, welcome everybody. It's wonderful to see everybody here. Super exciting event. Some of you I was able to have this morning for breakfast at my house. It's been an absolute honor to put this together and be able to work with the staff and speak to everybody as we've prepared to do this. And so really grateful that everybody's here. Super excited to hear from our amazing partners at Idaho State, at Portneuf, and from Health West. And I will be, I've got some other things I wanted to do as far as announcements, but I'm going to do that later during my CME with some other presentations I have. And so I think that's probably all I need to take at this moment. So thank you.
We're delighted to have our president here, Robert Wagner. I'm so glad that he's with us. Do come up and tell us what you are getting involved with and with our program.
Wonderful, Dr. Cree, thank you very much. I'm so excited to be here. Thank you for all of you being here this afternoon. I'm going to go through some prepared remarks, but please know just how much of an honor it is for me to be among you, to be associated now with the traditions and the legacies of these programs. For 30 years, the Idaho State University Department of Family Medicine has worked to respond to the healthcare workforce needs in Idaho by growing the number of family physicians caring for our citizens. In my short time at ISU, it has been deeply fulfilling for me to learn about and witness firsthand the positive impact. Through diligent work and collaborations with partner agencies, Idaho has seen significant growth in the number of seats for physician residents and fellows available in the state, with an 85% increase. That's incredible. ISU is moving forward. Undergraduate medical education has grown as well, thanks to a number of our health partners like ICOM, as well as WWAMI and the Idaho legislature and the State Board of Education. These increases have contributed positively to the overarching goal to bring more physicians to Idaho and improve access to health care for those who need it the most. This is a positive change that we can all be proud of. As Idaho's population continues to grow, the need for family physicians and all healthcare professionals has expanded. ISU is responding. The Department of Family Medicine at ISU has created a foundation of success that will continue to flourish, recruiting and retaining more doctors ready to respond to the individual medical needs of this state. And can I say that in just my short time, I started in the middle of the Idaho State Legislature. My first day was at the legislature. And can I tell you how wonderful it was for me to speak to, then not knowing much, perhaps reading from a script, but speaking to legislators about our health sciences capacity and the ways that we're meeting the needs of the state, and how positively legislators have responded. Our reputation at the legislature is fantastic. It's stellar. And the legislature, I believe, knows the important work that we are doing as a state institution in addressing the needs of this state. And so thank you very, very much. Through the years, faculty and staff at Family Medicine, working alongside many supporters, have championed sustained growth of not just the family medicine residency program, but also have expanded to offer pharmacotherapy residency, community-based pharmacy residency, psychology internship, and psychiatry residency rural track. Today we celebrate all of the distinguished graduates that have completed their residency training here in Southeast Idaho over the last 30 years, 8 of whom will graduate here this afternoon. When I first came into the room, I wanted an opportunity to meet all of you, but I was drawn by the pictures and was able to walk that line and really just feel, again, the legacy that these programs are, what they mean to this institution, what they mean to our communities, the communities that we serve. We know that residency location and clinical rotation locations are a strong driver in a medical provider's decision of where they choose to practice. Now, this is something I'm very proud of. Over 55% of physicians completing a residency in Idaho have chosen to remain in the state. At Idaho State University's Department of Family Medicine, where they've provided training and support for 173 family medicine physician residents over the last 30 years, over 100 of those physicians are still practicing in the state of Idaho. By the way, that's something the legislature loves to hear too. I think that's worthy of applause, please. The success of this program is due to the dedication, strategic vision, innovation, and resilience of the department. Indeed, I thank my colleagues here at Idaho State University for their excellent work. But it is also thanks to our collaborations with industry partners. By forging and fostering partnerships with other individuals and entities working towards the same mission, the leadership at Family Medicine over the years has positioned this department as a flagship of ISU statewide leadership for health sciences education in Idaho. These partnerships are too numerous for me to list this afternoon, but I do want to recognize Portneuf Medical Center and Health West for their unwavering support over the last several decades. These two organizations have truly been game changers in the success of our residency programs and our health programs. Both organizations have provided clinical rotation locations for residents to develop into the providers they are now. They have committed substantial financial support and human resource capital that are critical in making these programs successful. They have offered stipends to residents as they begin their residency, and they have been consistently at the table to determine the best ways to grow these opportunities to respond to our unique needs in the state. When I think about all the ways they have contributed to their programs, I am in awe of their allegiance, their dedication, and amazing support to ISU through many years. We are incredibly grateful for their support. Please. I also want to recognize all of the rotation sites where the residents are able to work during their time here in Southeast Idaho. Countless organizations such as the VA, the Bengal Pharmacy, and hospitals across the state and in Utah contribute to the learning and training experience of these residents, allowing them to explore their own passions as they care for people in these communities and grow into compassionate providers. Thank you to each of these locations and all of the people who support the residency programs here at Idaho State University. Please give them all an applause as well. Together, we will continue to fulfill our collective mission to improve access to quality health care for Idahoans. Graduate medical education is changing for Idaho, and we are on track to see continued success for many decades to come. ISU is poised to boldly move forward in addressing the state of Idaho's health care needs. Together, we will make a difference and positive impact. Thank you all again. Thank you for your efforts, for your work, for your collaboration. Thank you to the graduates, to the alumni. Thank you for what you mean to the state, for what you mean to these professions, and for what you mean to Idaho State University. It's been a pleasure to be here this afternoon. I congratulate the graduates, our faculty, and all those in family members, all those that are involved. And lastly, go Bengals. Thank you very much.
Before our next speaker, I'd just like to extend some welcomes personally. I'm so glad to see graduates here, Brad, Dan, Masumi, Melissa, Skylar Shippen, and from pharmacy, Jordan, Eliza, Cassidy. It's just lovely to see you, James Marble, and our faculty and residents from the current program. It's thank you so much for coming. And we have one of our original founders here, Ron McEwen, who many of you will not know. He recruited. Could you stand for a second, Ron? Ron was one of the first people to get the program going in 1992, way back. So it's delightful that you're here. Thank you for coming, Ron. We're going to move on to Portneuf now. And John Abro is going to talk to us a little bit about the history with our relationship. That relationship has been so important. And my relationship with John, I constantly have asked him for money for the last 30 years, and he's been very helpful.
Thank you, Dr. Cree. So before I gave this speech, I asked Greg how much time I had. He said 5 minutes, and then he's going to mute my mic, so I have to make sure I hit that time frame. Hello, everybody. John Abreu. On behalf of Portneuf Medical Center and the ISU Family Residency Key Partners, it is my honor to speak to you today as the Hospital Chief Financial Officer at Portneuf. And as part of the leadership team, I offer a collective congratulations to this year's graduating class and all the classes that came before you, as well as those individuals and institutions that have been responsible for such a world-class program. So as Jonathan kind of mentioned, my involvement in the program began in November of 2009, and actually it probably started before that. I interviewed for the job that summer. I became the CFO at Portneuf on November 1st, 2009. And I remember Dr. Cree was one of the interviewers for that position, and he automatically knew my experience with residency programs, which was zero. He had looked up my as-filed cost report from Matsu Regional Medical Center, knew the figures better than I did, and I knew I was going to be in for a challenge with Dr. Cree, just because he had meticulously studied the cost report, and he essentially was telling me, yeah, you have no idea what I'm talking about, do you, John? So, and he was right. I really didn't at that time. But one thing I did understand from that interview is Dr. Cree's extreme passion for his program. He was accountable for it. He understood the figures, as he would say. He refers to that often, and he's right. I mean, he gets it. So over the next several years, we worked on a collaborative agreement between the two entities to make sure that this program would be sustainable in the future. And then even over the next several years after that, both Brandon and Greg and I have worked to continue that. And then I think Greg just told me that our agreement has expired, so nothing like a burning platform to get everything going again quickly. So thanks for letting me know that before this presentation, Greg. Appreciate you. So as CFOs kind of go, I think I viewed the relationship between Portneuf and Idaho State a little bit differently. Most for-profit CFOs usually want to kind of squeeze every benefit they can out of a contract, right? You're negotiating this deal, and you want all the dollars you can to kind of go towards the sponsoring facility. But I kind of took a different approach. And I guess my focus was really on the long game. And what do I mean by that? So how does Portneuf continue to grow and develop a strong partnership with ISU residency program? I didn't want it to be a transaction. A lot of people sort of look at things transactionally. I wanted it to be, how do we develop this long-standing relationship and that can sustain a program and endure that program, so that program endures over years and years. The second thought I had along sort of that long game thinking was, how do we continue to attract and retain residents? I mean, when you sort of look at the cost to recruit, it's a big number for the hospital, especially coming to Pocatello. Just this idea of keeping doctors in our community and taking care of our patients was really a no-brainer to me. And by the way, that's coming from a guy who is a product of the Alaska public education system, now currently ranked 48th in the USA out of 50 states. So, I mean, if I could figure this out, I figured, it's really seemed like an obvious way to go. So another indicator for me as to why this program is important and valuable kind of stems from my early experience as a CFO. When I became a hospital CFO, started CFOing in 2001 when I was living in Alaska. And when you look at strategic plans, one of the things we do in hospitals, we look at sort of the supply-demand analysis. How many doctors do we have for the demand for that service? And everywhere I've been in the last 25 years as a hospital CFO, there's always a deficit of primary care. Always, without a doubt. It's top deficit on the supply-demand analysis. And even Pocatello is no different. As a matter of fact, I looked up the latest supply-demand analysis that we currently use. And in our CMS service area, they say there's 38.8 general primary care providers with a demand for 62.8. So we have a deficit of 24. And so, I mean, it's a big deal. It is one of those things where, we look at it and say, our primary focus is primary care, no pun intended. And I mentioned that I worked in Alaska. You may not know this. I did grow up in Alaska. I played hockey in Alaska. I'm going to give you an interesting random fact that you may not know. This is another connection I have with the ISU residency program. I play inline hockey in Pocatello, and one of my competitors is Dr. Kyle Clifford, former resident. And another competitor, actually a teammate, is Jordan Bailey. And so I played against those guys. That's my hockey ISU connection. You probably are wondering secretly, okay, John, are those guys any good? The answer is yes, they're very good. I think they're both from Canada, so it's kind of an unfair advantage being from U.S. Cannot compete with Canadian hockey players. And I will also say I might be a little bit more competitive if I weighed like 30 pounds less and was like 10 or 15 years younger. I might be able to hang with those guys. But so where am I going with this? I know I feel like I'm ADDing all over the place here. The reason I have this hockey reference is I think the folks in this program and the graduates of this program sort of get what the great one Wayne Gretzky said. And he said, you skate to where the puck is going to be, not where it has been. And I think you guys have seen that, right? I mean, this is one of those fields where by choosing this field, you are going to be skating to where the puck is and the future of healthcare. So as I sort of in my career, as I sort of went through this relationship with Dr. Cree and Brandon and Greg, we sort of talked about the family medicine residency program, I started thinking about this in terms of like population health. And many of you may have heard of PQA, which is our clinically integrated network, a Pop Health network. And this was started by me and Dan Ordina, the CEO, in 2013, sort of thinking about the importance of primary health care in this country, and especially in eastern Idaho. I mean, the population health model is completely primary care driven. It's the way to lower health care costs. It focuses on satisfaction. It focuses on lowering costs and quality and all these things, access. And, with the help of the primary care physicians in PQA, over the 13 years, we've returned over $15 million in shared savings. This is not stuff the hospital's doing, although we're doing some of it, but it's really driven by those primary care physicians that are the gatekeepers to being able to control costs, but also to improve quality and patient satisfaction. And currently PQA, which, by the way, it was called Portative Quality Alliance, is now called the Patient Quality Alliance, manages over 30,000 lives in southeast Idaho. And we recognize the importance of primary care in that model because we have now moved from essentially a shared savings fund distribution model where it was 50-50 split between primary care and hospice. We are now at 90% going to primary care and 10% going to, I said hospice, I meant specialists, because we recognize the impact that primary care physicians have on patient outcomes and how important this program is in developing the future primary care physicians in this region. Okay, so what does this all mean from my perspective? So as family medicine practice providers, you are the future of healthcare. Your role is vital in ensuring the well-being of individuals in our community. Your contributions to the hospital are vital to its mission, but also your contributions immensely impact our financial viability, speaking from CFO perspective. So I would like to just congratulate everyone involved in this program over the last 30 years. It's an incredible accomplishment and a testimony to the resilience and talent of the people who have made a difference in the lives of so many by their contributions to this amazing program. Thank you very much.
Just to add another figure to John's, I think the latest figure for a family physician bringing money to a community is around $700,000 a year. So if we've got 100 graduates in Idaho, think about the math of that and what we contribute to the state. Crystal Madsen's going to talk to us a little bit about Health West and our relationship. Would you like to come up, Crystal?
Can you hear me okay? First of all, I had 24 hours to prepare this. My name is Crystal Madsen. I'm actually representing Health West on behalf of Mindy Benedetti, our Health West CEO, who sends her congratulations to you all. As an ISU alumni myself through the Casissa Health Sciences, class of '95, and the current clinic administrator at the ISU location. So Healthwest ISU, currently the clinic administrator. I've been there 3 years. I'm honored to be a part of this, a small part of this great celebration of 30 years commemoration. So thank you for that opportunity. In 1994, when a few of you graduated, I was actively engaged in my healthcare administration undergraduate. I was doing my internship at that time. I was at the hospital up on the hill at that time, Pocatello Regional, and did an exciting things in healthcare. As that was all the buzz, a lot of things going on at that time, and loved my experience in that role, and learned so much about healthcare and what was developing in the community, including the residency, believe it or not. So I go way back farther than some of them know. I've been at my role across the street for the last 3 years, and loved every minute of it. Throughout my 30-plus year career in healthcare, I've been in the hospital, I've been in primary children's, pediatrics, I've been in the specialty areas, and throughout my career, I've been most drawn to family medicine. And the reason for that is that I have found that in family medicine, it's more about the connection, right? You all know that. That's why you're here. Sustainable, patient-centered medical home for the whole lifetime, okay? That has so much meaning to it. Greater compassion through continuity of care and meaningful provider-patient relationships. I always had to be the one that said, oh, we're going to disconnect this patient-provider relationship because it's not working. That's a hard thing. So many work and such an honorable thing and an inspiration to me, the provider-patient relationship that are built for a lifetime. At Health West, we are proud to be a partner with the ISU Family Medicine Residency. Our missions align, and I'm honored to be a part of that. So Health West ISU is one of the busiest clinics out of the 19 locations that Health West currently has. And as an academic center, we have a wide variety of services. We do everything there for the academic purpose. And it's not just family medicine clinic, right? It's not just primary care. We do all the things and then some. Our partnership leverages resources from multiple organizations, and we can achieve greater results than we could do alone. Our partnership benefits both the residents that are providing care as well as our patients. And our staff, I want to talk about our staff. Our staff are dedicated to this very fulfilling work, and it is fulfilling. And the academic growth of the provider, they're dedicated to that growth of the provider. They realize when this new intern comes in, they're a huge part of that experience and that learning and growing and developing. And they usually stay. We try to find coverage sometimes within our system, and, oh, I don't want to go up there. I don't know how you do all those things that you do. It's different there. Yes, it is. It's different, and it's very special, and we love it. Patients have access to high-quality doctors that are right on the cusp of their great careers. Residents have the opportunity to work with patients from all walks of life. So what a great opportunity that is. I'm very grateful to work alongside all of you every day. There's no place I'd rather be. That's where I want to be. I'm on what I feel like is the tail end of my career, and this is where I want to stay. I'm honored to be here and celebrating with you today. So thank you.
Hello, I'm Bill Woodhouse, and I'm here to start introducing our speakers for our CME portion. And our first speaker is well known to you all. It's Dr. Cree. He's going to talk about 50 years of experience in medicine. And we all know that Dr. Cree is from England. He's graduated from Oxford University Medical School, but has been in graduate medical education for almost his entire career since, both in California and here. He has served in multiple capacities in regional networks and WWAMI. He has been transitioned from program director to chair over the past decade. He was getting ready he stopped seeing patients last December and was getting ready to focus on beekeeping when he got a grant which led to a recent humanitarian outreach to Namibia, which he just returned from, to help address their high maternal and neonatal mortality rates. Anyway, he's here with his wife Holly, and he has 2 children and 4 grandchildren. And please join me in welcoming the current IAFP Family Physician of the Year, Dr. Cree.
I got my medical degree in Oxford in October of 1973, and in October of 2023 I was elected to this elite and rather small group of 50 yearers by the IMA. So my goals are to examine how these advances have changed expected lifespan, knowledge discoveries that have changed our understanding of disease, take a look at social media, and talk about some of the lessons I've learned I hope you can apply to your careers in medicine. How do you pick and choose so many things in 50 years of medicine? A surgeon would choose laparoscopies and procedures, cardiologists, nucleotides, oncology, targeted immune therapy, radiologists, PET scans. So what does a family doc choose? Well, I chose 20 prevention procedures and 20 antibiotics, 20 vaccines, 20 surgical procedures, and I'm going to do this for 20 minutes. And I'll present some patients who died of now treatable diseases. I'm going to ask you to name those diseases. Sorry, graduates, there's going to be a bit of quizzing as part of this. So this is vagintophilia, that's love of 20, rather than vaginophobia. That was a very famous article about hyperbilirubinemia in newborns, and in 2004 the Billy blanket was invented, and you may think, well, why do you start 50 years of medical advances with Billy blankets? Well, it certainly changed my life in obstetrics of being able to get newborns home so they weren't sitting under lights in the hospital, and get mothers and newborn babies together and home parspin care. And as I thought about that, I thought, well, really, home care is something that is very dear to my heart. I used to buy a house call bag from this pharmacy, John Bell and Croydon, that was opened in 1798. Can you imagine a pharmacy opening? Pharmacists? You go back a long way in London, so... well, that got a little bit expensive, so I buy house call bags here now, and I give one to one resident every year. I've done that for the last 50 years. Nick Henry got a house call bag. And actually, it's a tremendous skill to keep someone who is disabled and at home for the last decade or however long of their life. You have to be a team leader with nurses and community resources. You have to organize them, and you have to do the right amount and not too much. And all those home nursing things that are on the slide are available. There are 3 home hospices in Pocatello and 2 home hospice directors here, Travis Nielsen and John Festemaker. So I think this is really a very important medical advance in the last 50 years. So do advances in medical practice make a difference? When I went into practice in 73, the life expectancy was 68. 2024 life expectancy is 80. Well, it's not all due to medical advances, nutrition and other things, but I think it speaks for itself. I might state at the outset that there are some things that haven't advanced. I'm wearing a stethoscope tie, so stethoscopes still work, provided you don't use them through clothes. Please, residents, graduates, just skin, please. I found out today from my daughter, who's a pediatric endocrinologist, why so many pediatricians wear bow ties. Does anyone know why they wear bow ties? Exactly, yeah, the babies grab your tie and strangle you, so you don't want to wear ties around babies. One of the first things I dealt with was contraceptive technology and the sexual revolution. This was in 1973. That was the 5th year of the Royal College of General Practitioners study, which started in May of '68. Can you imagine a study of this size now? 1,400 general practitioners. My practice in London was one of those practices. We recruited 23,000 women and we followed them right until 1996. Can you imagine putting a study like that together now? In 1973, we had the statistics up to 35. They publish statistics every 5 years. Is it safe to give it up to 30? Yeah, okay, great. Is it safe to give it up to 35? Great, okay, we'll give it to our 33, 34-year-olds. And then in 73, it came out with, well, between 35 and 40, if you're a smoker, you're liable to have a stroke. So we didn't give pills to them, and it's the same nowadays. And neurological migraine is a problem with a contraceptive pill. It's very interesting, in 1968, people wanted to see periods. Women wanted to see periods. They wanted to know they weren't pregnant. That's not true in 1996. Forget those damn periods. Give us the pill every day. We don't need to see blood. So that was a change which I found kind of interesting. Obstetrics, going on from hyperbilirubinemia, I think the biggest change that I saw in obstetrics was defining the active phases of labor as 6 rather than 4 centimeters. I did obstetrics for about 30 years. Delivered about 1,200 babies, and we had so many C-sections because of delay between 4 and 6 centimeters, so that's made quite a difference. That was introduced in around 2011, 2014, so I've put those on a timeline, and this timeline will build up in the next 20 minutes or so as to things in each of the 5 decades of my 50 years in medicine. So let's talk with a genetic disease. In 1985, okay, get your thinking hats on, everyone. I was called to the ED at Northwich Hospital to see a 15-year-old black male new to the community, presented with joint pain and a hemiplegic stroke at the age of 15. His hemoglobin was 7, blood smear was taken. He died of recurrent aspiration pneumonia. He had no protection of his vocal cords. He had total dysphagia. Diagnosis, please. Sickle cell disease. He had a sickle cell crisis, exactly. So here's a picture of blood cells sickling and causing tremendous blockages in arteries throughout the body and in the joints. Well, in 2024, this year, 40 years later, the first sickle cell patients are undergoing gene therapy. The name of the drug is called Casgevy. Each patient has their own stem cells collected. They're kicked out of the bone marrow by a procedure. They're collected, and then they're individualized with Casgevy to program hemoglobin F to be produced. It takes 6 months to program those stem cells. Then the bone marrow has to be kind of turned off so that it will accept its own stem cells back. Can you imagine all these phases that people have to go through? The stem cells are then reincorporated in the sickle cell disease patient's bone marrow. They start making hemoglobin F. They are cured. Can you imagine? What an advance. I mean, the people who thought that, I think it's just amazing. What's this disease? Another hemoglobinopathy, great big bossing. I had another patient who was a teenager who died of this disease. What is it? Any thoughts? Maxillas making blood cells. This is thalassemia major. And they're going to be next in line for this gene therapy. So these hemoglobinopathies are going to be cured. All right, so 20 antibiotics, 110 new antibiotics in the 50 years I was in practice. So imagine what life would have been without these cefuroxime, ceftriaxone. Can you imagine if we didn't have these? Mupirocin locally, the clavulanic acids, Cipro, Azithro, levofloxacin. I'm on azithromycin at the moment with my bronchitis from COVID. I'm on day 5 of COVID, by the way, so if I don't make sense, there's a reason. So linezolid, daptomycin, how much we've used that drug. So I think these are just amazing pharmacological advances that we have been able to put to use. Case number 2. This was in my first year of practice in California. This gorgeous woman came in. I was not immune to her charms, but she's 27. She brought her lovely 3-year-old redhead in as well. And she presented with an axillary mass. It looked like this. And of course, I was horrified. I examined the rest of her. She had a scar on her left scapula. She stated she had a mole removed a year earlier. Diagnosis, please. Malignant melanoma. She died a year later. Can you imagine? Awful disease. Okay, well, 5-year survival from metastatic melanomas increased from 5% to over 50%. Our former psychologist still lives with his malignant melanoma, John Dickey. So how is that done? It's gene sequencing targeted therapy. That means that specific targets on the melanoma are identified and genes are identified so that they can target those parts of the melanoma and kill them off. That's a huge advance. In St. Thomas's Hospital where I trained, we had a malignant melanoma ward. It was the most awful place. They gave oncological drugs through the lymphatics into their feet. I had to inject their lymphatics in their feet. It didn't work. All right, this is where we live, our prevention, and I'm horrified to say it's been turned into quality metrics, which we all have to follow. We all just got a letter from Health West, thank you very much, about our quality figures, which aren't particularly good. So I picked top 20 A and B recommendations. These means that there's very good evidence for them. AAA screening, mammography, pap smears, STD testing, Hep B and Hep C screening. What are our figures? They're never good enough. HIV screening in pregnancy, we're pretty much 100% on that. Hypertension, we do well. LD CAT scans for smokers. DEXA scans, diabetes screening, PrEP for HIV patients. Statins for people with cardiovascular risk. So these are all things where we live, and they've all been introduced in the last 50 years. A huge change from when I went into practice. Case number 3, 45-year-old male presented with fatigue, shortness of breath when I was an intern in 1974, my second year as a doctor. I was working at Canterbury Hospital, I still remember it. His workup revealed pancytopenia with a hemoglobin of 5. He was short of breath. This was his bone marrow. Diagnosis, please. Come on, guys, shout it out. Is anything making any cells there? Aplastic anemia. His bone marrow has got nothing making anything. His bone marrow is replaced by fat cells. Read out as aplastic anemia. I took a more detailed history. He'd had 3 tablets, 3 tablets of phenylbutazone. That's like Advil for horses. Now the trouble is when you give phenylbutazone to human beings, it turns off their bone marrow, which we didn't know when we started handing it out. So he died from those 3 tablets. 1974, 1977 was the first bone marrow transplant that would have saved his life. By 1989, there are millions and millions of recorded potential transplant donors and recipients. It's a worldwide phenomenon, and it is very common. Stem cells help this.
Many of you work with George Marshall and me, are my brother-in-law who's alive because of a bone marrow transplant. He had aplastic anemia as well, and was able to get a bone marrow transplant. And is still now training and teaching residents and working in the hospital.
I'll never forget the face of this patient, one of my first patients who died, when I told him, we can't cross-match you anymore. We don't have any more blood that'll work for you. Not a good moment. So he went into hospice care that had started 4 years earlier in my practice by Cicely Staunders, and she did inpatient hospice. Hospice is now established worldwide, and it's usually done at home and is done with great care, with great dignity. And I'm very grateful we've got 2 excellent hospice directors here who do that. Okay, vaccines, on we go. All these vaccines became available during the 50 years that I was in practice. Haemophilus influenza is one that I picked out. I don't think any of the residents here ever saw epiglottitis. Did any of you see epiglottitis? Bill and I will tell you about it. You have kids who they're sitting on the edge of a chair like this and they won't move. Do you remember, Bill? They just won't move because if they move, their epiglottis will close off their airway. They won't move. They have this huge epiglottis, and you have to phone your ENT surgeon and say, I'll meet you in the ED. And you very carefully wheel them over to the emergency room. And the ENT surgeon has a tracheostomy ready, and he most of the time can intubate, but sometimes they can't. And you have to do a tracheostomy. Otherwise, they just die. So I was so grateful for Haemophilus. And I think there's going to be, in your time, a whole new era of anti-vaxxers medicine. I do hope you don't have to see epiglottitis. That was horrible. Acellular pertussis was a great advance because the whole cell pertussis caused so many damn reactions, and I think that was the start of the anti-vaxxer movement. So COVID vaccine was a huge advance because it was the first mRNA vaccine, and it targets the S protein. mRNAs are the molecules that instruct cells what to build. Once the S protein is produced within the body, and you inject the mRNA to make the S protein produced, it's considered an antigen. And then the body produces these antibodies, and it helps kill the COVID. So that's how COVID vaccine works, but there are so many mutations, it's not foolproof. So I just had COVID for the 3rd time, and I had 4 damn vaccines, but I'm still going to have the 5th if it comes around. How many deaths from COVID? 7 million out of 704 million cases. And that's a weekly average of daily deaths. Okay, case 4. Are you ready for this? It's 1985. I'm working at the ICU at Northridge Hospital in Los Angeles. I was called to a 25-year-old male with severe shortness of breath, respiratory failure. It's his chest x-ray. Diagnosis, please.
HIV,
Pneumocystis from HIV, very good. These aren't difficult cases, and you're all doing very well. You'll all get your boards. Good for you. Okay, he died in 24 hours. These people would come in and they'd pant themselves to death. Hundreds and hundreds of young men. Oh, it was an awful year. Any of you who are physicians in that year, it was an awful year. Had all of these things, and people like Rock Hudson and Arthur Ashe would come out and they died. Philadelphia, the movie. Ryan White was a 13-year-old little boy who had hemophilia, and he got HIV from a blood transfusion, and a fund was set up in his behalf. We have Ryan White funds in our clinic, lots of testing advances. And this was when Indinavir was introduced, 1995. Didn't really affect the whole world. Do you know why? Because of the damn cost. It costs $10,000 per person per year. Médecins Sans Frontières set up a committee to bring down the price of HIV drugs. They brought it down in that 10 years from $10,000 to $61 per person per year. If you guys follow the news, you'll have heard that Médecins Sans Frontières is defunding that advocacy committee. There's a big controversy about it. A lot of trouble. I hope they change their minds about it. Okay, case 5A and 5B. These are the last cases. And there's no questions. Well, there'll be one question as it comes through. Sue Harris, she was a family friend, called her GP, who was my father. Panicked. Her 45-year-old husband was clutching his chest and turning blue. My dad leapt out of bed, waked all of us up, grabbed his household bag, drove like a maniac, and gave what he called adrenaline, which we call epinephrine, directly into this fibrillating heart, saved his life. He gave up cigars and commercial real estate. He was maintained on Coumadin. That's how we treated MIs back in 1959. We thought MIs were due to blood clots in stenosed arteries. No statins, no AEDs. Well, the GP, my dad died of an MI in his late 70s. And his son, me, had his MI in 2019. And I was resuscitated, converted from VFib to sinus rhythm with an AED. There are AEDs all over the place. Does anyone know where it is in this building? It's round the corner, I can assure you. I check where the AEDs are. Well, I had an angio and a stent in 40 minutes. That was a pretty damn good time. So this isn't my coronary artery. My coronary artery was much worse than this. But my LDL's 38. I'm on 2 anti-statin drugs. It was 120. Carvedilol and Lisopril gave down my blood pressure, and I'm on aspirin for platelets rather than Coumadin. I have a decent echo. I'm very grateful to be alive. My presentation was toothache. How many of you knew that toothache can be a presentation of angina? Anyone put their hand up? I'll slap it down. Okay, 20 quick procedures. Interventional radiology, EMIs, CPAP from Australia, Helicobacter in 85, changed our treatment of ulcers, pre-selective vagotomies, ultra-selective. You guys have no idea the surgeries we went through for ulcers. Angioplasty stent, now drug-eluting stents, Neupogen. Da Vinci robot was a damn good thing. TAVRs, they were introduced in France. And EMRs, I reluctantly had to put that on here. POCUS, I wonder where POCUS is going to lead. I think that's going to have a great future. semaglutide, of course, for diabetes and obesity. If you just took one of those, endoscopy, I mean, look how it improved over its 2 decades. It developed retrograde cholangiography, gastrostomies, control of bleeding, variceal ligation, all of these developed from one. So here's my final list. I picked 25. I just presented you with 100 advances. I've picked 25 of them. They're my picks. I hope you've enjoyed this look at the last 50 years. I remain passionate about medicine, as you can tell. I hope you do too. And, well, maybe the 50th graduating class in 20 years. Who knows? The doctor-patient AI relationship. Thanks for taking this journey with me.
And as we mentioned earlier, it gets more clinical. I leave that up to you as to whether you want to hang around and listen to that. Our next speaker is Brandon Mickelson, director of the ISU Family Medicine Residency. Brandon was born and raised in Pocatello. He's an ISU grad. For undergraduate, he went to the University of New England Medical School and then came back for residency here at the ISU Residency, where he has been on faculty for over a decade and has been director for the past 10 years. He's past president of the Idaho Academy of Family Physicians. He's the current District 7 trustee to the IMA board. He's a CCD certified clinical densitometrist for the last 14 years, and he's read nearly 10,000 DEXA scans. He's married to Jen with 5 kids, and he's going to talk to us today about osteoporosis. Brandon.
Thank you, Bill, and Jonathan, thanks for your talk and not making us have to use the AED during your talk. We appreciate that. Every time you talk about that, I get PTSD from sitting on the medicine floor getting that call. So we're going to run through some osteoporosis today, hopefully share some things with you that you need to know and need to be changing probably in the practice that you're doing. And so, again, I don't really have any disclosures there. We talked about I have a lot of experience there. I've really been functioning as kind of the expert in osteoporosis in Southeast Idaho for a lot of years and get a lot of referrals, and so I end up taking care of a lot of the complicated patients here in this area. So we're going to talk a little bit about treatment, workup, secondary workup, and talk a little bit about FRACs and some of the things that are coming forward with FRACs. So epidemiology, again, this really shouldn't be a surprise to you. Osteoporosis is very prevalent. There's a lot of it out there. And it really plays a huge role in people's health. But again, if you'll look there, 1 in 6 hip fracture risk in women versus 1 in 9 for breast cancer. Again, not to downplay breast cancer, but again, this is a huge player. And as I often say to my elderly patients, what do we care about? We care about you want me to keep you out of the nursing home. What puts you in the nursing home? It's strokes and fractures. And so this really plays with independence here. So when and who to screen, this really shouldn't be a change for most of you. And so again, 65 years old women really should be where you're thinking. And then again, you'll see up there, I usually say about 10 years after estrogen deficiency. So I'll get questions all the time. So you've got the 30-year-old who had a premature hysterectomy, was not put on estrogen. Yeah, probably age 40 is when you want to be looking at their first DEXA scan. If they're put on estrogen replacement, they probably become a 65-year-old woman again there. But if you use 10 years as kind of your rule, I think that will be a good rule of thumb for you. Men are difficult. 75 is probably what I encourage people to start with. The problem with men is Medicare, who we're normally dealing with, doesn't cover DEXA scans in men unless it's abnormal. And so you really want to only order DEXA scans on men that you anticipate are going to be abnormal. The exception to that would be steroid therapy or a low trauma fracture. And so when you have steroid therapy, low trauma fracture, easy to do with a man. If you don't have those things, 75 is probably where I'd want you to start thinking, but you give me somebody who's had gastric bypass surgery as a male, longtime smoker. Again, I'm going to be way before 75 in doing that DEXA scan, but you've really got to kind of just take some clinical decision making there in what you do with men. Up there I've got Canalog. Again, hopefully Canalog is going by the wayside, the Canalog days for allergies, but I've seen way too many people through the year with osteoporosis from the yearly Canalog shots, and so be really aware of that. And I've even seen some people with joint injections, lots of joint injections, where that's the closest thing we can tie it to their early, and on rare occasions, topical steroid therapy. So don't underestimate your other steroids when you think about osteoporosis there. And then, again, be aware of your thin white females who smoke. I mean, those are some of the worst osteoporosis cases that I see all the time. And then past illicit drug use. All right, so the reminder here is that osteoporosis is diagnosed, really kind of the way to think of it is 3 different ways, okay? When you give somebody a diagnosis of osteoporosis, you're all pretty familiar with DEXA scan, okay? So T-score, what's our T-score cutoff for osteoporosis? Okay, so 2.5, 2.5 standard deviations. And do we ever use Z-score to diagnose osteoporosis? We don't. We don't use Z-score to diagnose osteoporosis. When Z-score becomes abnormal in our young people, we talked about this the other day in Dr. Vandergreen's lecture, for those of you who were there. Again, that's low bone mineral density for age. So again, it's not osteoporosis where we're starting to use the Z-score. But so 2.5 or lower. If they have a low trauma fracture, what is the definition of a low trauma fracture? I don't even have an answer for you. I don't think anybody has an answer for you. The obvious ones are what? Fractures of what? Or slam dunks? They fall and break what? Hip, slam dunk. They reach up to change a light bulb and break. Their back, right? They get a compression fracture. Back and hip, those are easy. Those are absolutely low trauma fractures. What about the person who steps off a curb, twists their ankle a little bit and breaks it? Is that a low trauma fracture? I don't know the answer to that, but I do get a DEXA scan on those people. And it's interesting. You get those that have severe osteoporosis. You get others that it's stone cold normal. Again, those are the type of fractures that it's really hard to interpret and know what they mean. But then the other one that becomes really important is if somebody has a high fracture risk on fracs, you really should be labeling them as osteoporotic, okay? Their DEXA scan shows osteopenia, but they have a high, and again, the cutoffs are up there, greater than 20 and greater than 3. That's an osteoporotic patient. Because again, osteoporosis is taking into account their overall fracture risk. And the reason I emphasize that is because when you try to put somebody on certain treatments, insurance companies will always, not always, but routinely balk at osteopenia. They're much less likely to balk at osteoporosis. And that person does have osteoporosis. I don't care that their DEXA scan said osteopenia. They have a very high fracture risk and they're an osteoporotic patient. And so again, make sure you label them appropriately, not to play the game, but because that actually is the diagnosis that they have. And then another question that I get all the time is when to reorder the DEXA scan. So I've got a bunch of numbers up there. 1-year DEXA scans you should do next to never. The 1-year DEXA scans are those who have a T-score of -4, -5, just severe, and you're like, okay, we've got to watch this really closely. Most of the time it takes at least 2 years to be able to see enough of a change on a DEXA scan to make it worth your while. Your osteoporotic patients, you're about every 2 to 3 years. Your osteopenic patients, you're every 5 years. Osteopenic that are low fracture risk, and then your normal patients about every 10 years. So questions about screening diagnosis before I keep us moving? Okay. So I just share this because there's a lot of question out there as to does DEXA make a difference? And no, this chart doesn't definitively answer that, but what you'll see there is when DEXA reimbursement went down dramatically, the number of DEXA scans, no surprise, went down dramatically. And if you start to look at what was going on with hip fracture rates, you start to see where we had a huge change there. And so again, this really, no surprise, this is really just emphasizing that when we're out looking for a disease and we find it and are able to treat it, we generally make a difference other than we have high-risk treatments, which most of what we do in osteoporosis doesn't really fall into that category. Yes, please. Nope, all of those will give you osteoporosis. So T-score negative 2.5, osteoporosis. Low trauma fracture, osteoporosis, and then high fracture risk on FRAX, osteoporosis. All right, so raise of hands. Who has used FRAX before? Throw them up for me, throw them up for me. All right, I'm seeing most of you. Okay, good. You need to be using FRAX. If you're not and your hand didn't go up, I want you to make that goal. You're going to have a chance to use it in the next month. You're going to have somebody whose DEXA scan is going to come back where you need to use FRAX. Google it. It'll immediately get you there. And then really you're doing country and race is what you're, well, supposed to do. That's classically what people have done. Now, what I get into is we have the most data around females that are Caucasian, right? No surprise, that's where we have the most data. Is there a racial difference? Yes, but where some of the controversy comes in is when you have lots of data, that data is always better, right? When you have small amounts of data, the data is not as good. And so what a lot of people in my world are recommending is that when you have the non-female Caucasian, you run it through FRAX as the, male African American, but then you actually go ahead and rerun it as a white, as a Caucasian female, and then look at those numbers to help you. Because again, there is a difference, male, female, there is a difference in races, but we have so much data with the white female, it's just more accurate data there. So that's where there's the controversy on what you put in there as far as race and sex. So a lot of times you will have issues where people are like, okay, I don't have access to the BMD or what was the machine done on. I usually encourage people just to use the T-score. So as a reminder, FRAX is going to ask you for a bunch of questions. You're going to put that information in and it's going to spit out their fracture risk for you. And that's what's going to give you that 20 and 3, well, the numbers that you compare to the 20 and 3 that I gave you earlier there. The other thing that I'll tell you that I use FRAX sometimes for is again, this principle here. Every now and then I get in this situation where I'm putting somebody on a drug holiday, and we'll talk about drug holidays in a minute. What is their overall fracture risk right now? Should I have them on a different medicine or not? And FRAX is not developed for that, but that at least gives me an idea of what their current fracture risk is and gives me at least a piece of information to try to help make that decision in what I'm going to do during that break with that person. And then again, I mentioned this earlier, but your questionable low trauma fractures, that becomes very helpful to me. But you also can use it to help you decide, do I get a DEXA scan? And so you use FRAC to give you a little bit of fracture risk there. Down there at the bottom, I have their FRAX 2 is in the pipeline. And what I'm going to share with you here in a minute is some of the information that will be on FRAX 2. I just share that with you because FRAX, there's a lot that FRAX doesn't give us. And so this is a little bit hard to read. But what you're going to see here, and again, no surprises, but this becomes important. So what they did is they took FRAX, but then they looked at what this information did to their FRAX score that's not tied into that. And so if you'll see here, somebody who's had 3 or more falls in the past year, their risk of fracture was up by as much as 63% of what FRAX said it was. So really what you want to think about is somebody who's got a high fracture risk, you want to look at that very differently when they've had multiple fractures. Does that make sense? And so then you'll see there recent vertebral fracture, recent humeral fracture. The data is really clear that the more recent somebody's fracture is, the higher their subsequent fracture risk is. So the person who had a back fracture in the last year, their FRAX score is going to vastly underestimate their overall fracture risk. So again, myriad of numbers up there. I don't know that we need to go through all of those, but that's what some of FRAX 2 is going to be giving us. But what I really want you to pay attention to is how recent was their fracture and how often are they falling. Your person who's falling a lot and has recent fractures, if their FRAX score is barely on the cutoff, you absolutely need to be labeling them as osteoporotic and getting them treated. Questions about that? Yes? Okay. Perfect, thank you. Never been told people can't hear me. Yes, there is. All right, so when do we do a workup? Share your thoughts with me. When do we need to do a secondary workup? Okay, so younger. Now, that's absolutely the right answer. What number on a DEXA scan is kind of age-related? So T-score is compared to what? peak bone mass, which is mid-30-ish. What is Z-score compared to? Age. So when whoever said younger, that's a right answer within reason. In other words, really what I want you to now focus on there is Z-score, right? Because that's what gives you a little bit of an idea of where they should be with that age. And so usually I will use 1 standard deviation as my cutoff when I start to consider a secondary workup, unless there's an obvious cause, right? The person who's had gastric bypass, I don't necessarily need to do a secondary workup. Now, I may need to do a secondary workup for things that the gastric bypass may be causing, but the person who's 40 has a Z-score of -2, that person, there's something broken, right? I need to find what that is, okay? What else? When else do we want to do a workup? So, what's that? I still didn't hear you more. Yes, absolutely. So again, really severe, which Z-score is often going to do for us, but certain ages, simply what the T-score is going to be of some help there. And then the only other thing that we didn't mention up there, so again, what is our, no obvious explanation coupled with severity, our Z-score, as I mentioned there, and then T-score that is significantly worsening. So I tend to use about 1% a year as a reasonable cutoff. So when you get that 3-year repeat DEXA scan, I send it back to you or somebody else does. It says they've worsened 10% in the last 3 years. That's somebody where you should say, okay, something is wrong here. We need to be looking, because around 1% is the rule I want you to think of. So 3 years later, they should worsen by about 3-ish%. Okay, if they're at 10%, something's going on. I need to go looking there. All right, non-drug treatment. Where are we? We're doing okay on time. So non-drug treatment, I've got a lot up there on there for you. Again, most of this is stuff that you're mostly doing and aware of. What I would continue to emphasize is, as far as non-drug treatment, we absolutely have the best data with vitamin D, weight-bearing exercise, and calcium. Again, hopefully these are 3 things that you guys are already emphasizing. Most of the other non-drug treatment, we really don't have. Not that the data we have is incredible with this, but this is where we have decent data. Pretty much everything else. So when your patients come to you and ask you about strontium and all the different magnesium and all the different things there, really the only good answer to me you can give them is we really have no data that is beneficial. That doesn't mean we have enough data to say that it's definitely not, but definitely no data there. Questions about non-drug treatment? Okay. So really, first line, we'll talk about a couple things, but I still want you feeling comfortable using the oldie goldie alendronate. Wonderful drug, wonderful data, and again, really has probably our best across the board data that we have. Reasonably well tolerated, cheap, very effective. So don't be afraid to use and think, oh, I've got to go with the newer, better things all the time. This is still an amazing drug that does great stuff there. Don't do it if they have swallowing problems. So one of the first questions I ask every single patient as I'm doing osteoporosis consult, do you have problems swallowing pills? Because immediately when they say yes, I know what I'm not using, and that is alendronate or my oral bisphosphonates there. And so make that just a quick question for you. Kidneys are of debate. With my oral bisphosphonates, I'll generally use 35 to 40 for my cutoff. With my IV, I will put that up to about 45 on my cutoffs there as I'm using zoledronic acid. So, and then severe disease, you'll see that I put there about 10 to 15% of people don't absorb oral bisphosphonates. You don't want to take the chance on that, and I'll talk a little bit later about some of the good data that we have recently when we're dealing with severe disease and the importance of anabolics, and that sequence does matter. So alendronate, 5 years, then you need to do a couple-year drug holiday. Yes, please. Wonderful question. Thank you. Thank you. And then this becomes really important. So what is our concern, first off, before I answer that question? Osteonecrosis of the jaw. Absolutely. And so osteonecrosis of the jaw can happen with any of our anaresorptives. It is the highest risk with our IV bisphosphonates. So zoledronic acid reclass has our highest risk of osteonecrosis of the jaw. So really when I say bad teeth, what I want you looking for is current bad teeth, and also that are likely going to need intervention. Where we get into trouble is when there is any sort of intervention that needs to happen into that jaw. And so when you look in that mouth and you see all these nasty teeth, and you say to them, what are your plans with your teeth? Are you planning on doing anything? The person who says, yeah, they're infected, they're nasty. I saw my dentist the other day. We're planning to remove them all in the next little bit. Okay, you're not starting treatment on that person. You're getting that taken care of. The person whose teeth are all removed is wonderful in this situation. That's not who you need. And then the other risk I just want you to think about is if they've got deep-seated infections, that's a little bit like work going on the bone in the jaw. And so, like anything, you have to weigh pros and cons here, right? And the person who has bad teeth but has severe bones and has no plans of doing anything with their teeth, you very well may need to be treating them, but that's going to be very much a risk basis. You have that conversation with them in making that decision. So, yes?
How long do you wait after major dental work?
There really is not a definitive answer, and a lot of it's going to just simply depend upon how severe it was. So the best rule I would give you is think about you want that bone to be essentially healed, right? And so somebody who has minor dental work, well, that bone is going to be healed in a very short order, right? Versus the person who had extensive dental work with implants and things like that. You know, you're probably looking at 6 to 10 weeks before you have complete healing of that bone. But just think of it, you want healed bone before you're putting them on there. Great question. Thank you. Other questions there? Yes.
From the last slide, sometimes I'll come back from like rheumatology on like the 50,000 D2 weekly. Is there any place for that versus just the vitamin D daily? I never know what to do on that. I hate to stop it from specialists, but I'm like,
There is no answer. Getting somebody up on vitamin D to me quick, there's no data that says that makes a difference. I don't know that it's necessarily wrong, but I don't know that it's necessarily right. What I do want you to have drilled into your head is vitamin D toxicity is real, and it happens, okay? And I've seen some nasty cases of people, and so really I didn't mention this, so I'm glad you're coming back to this. 2,000 is what I found to be the sweet spot in Pocatello, Idaho. I used to check a crazy ton of vitamin D levels. I almost never check vitamin D levels anymore, just because after lots and lots and lots of years, I found that 2,000 generally got me right where I needed to be with pretty much zero risk of toxicity. Every patient that I've ever seen that got toxic was on at least 5,000 or more, and whether it was daily or weekly depends on that total dose. But so what's being done there is not necessarily wrong, but to me there's really no data that it's right. And rather than trying to do this, let's do this for this long and then this for this long, I just try to keep it really simple, get them on 2,000 a day, send them on their way, and then they stay with that. So, good question. Keep asking. I want to make this as helpful for you as possible. So, second line, probably should be thinking mostly of Prolia and zoledronic acid. And what do we want to talk about with? So, Prolia, the emphasis that I would give you there that hopefully is not news to you, but so no indication for a drug holiday and likely harm, okay? So, don't stop Prolia, okay, unless you have really good reasons, and in that situation, consider transitioning to something else for a short term, okay? Prolia, you will absolutely get rebound bone loss. In some people, it's minor. There have been case reports of people having 4 and 5 compression fractures within a year and a half of stopping Prolia. With some people, they get severe rebound bone loss. Don't stop Prolia. If their bones get to a point to where they are just, I've seen patients improve by 20, 30%. Their bones get to a point where you look at their fracture risk and it is so minuscule at that point and you say, you know what, even if we get some rebound bone loss, I'm not worried about this person, consider stopping it. The person who you need to stop it for another reason, get them on alendronate, get them on zoledronic acid for a year. That will take care of that, and then you can get them off of everything there. So, questions about that? Because I'm sure for some of you that's new. This is the first time you're hearing this. Questions about Prolia and holidays there?
I assume you would do that, switch to something else. It's like 6 months dosing. You do it at the 6 month mark.
Yep, Absolutely. Well, first off, there is no right answer there, but that is the expert consensus, is that you would do it when you would normally be doing your next Prolia injection. So yeah, they got their injection in June, they're due in December, you're taking them off of it for whatever reason. We're starting zoledronic acid as a 1 dose and now you're done, or we're starting on alendronate for a year, whatever that might look like at that 6-month mark. Any other questions on that? Okay. And again, the continued emphasis, but this is a lot of things. Again, we have no fracture data in men there with it. Sometimes you'll have a hard time getting insurances to cover it, but usually not, and you usually still can get males on it. Zoledronic acid, really the big difference with it, going back to our alendronate. Obviously, we don't have the swallowing issue, higher issue of osteonecrosis of the jaw. Kidneys, I worry more about it, and so 45 to 50 range is usually where I use my cutoff. I usually want blood work within 3 months. And then you're going to do 3 years with zoledronic acid and then a couple-year holiday there rather than the 5 with your orals. And remember, a lot of times people get nervous about that. Bisphosphonates last forever, okay? When you give somebody 3 years of, there's even good data out there about doing every other year with zoledronic acid. I mean, they last forever. On some of the studies, they found it 10 years later in the bone in people after they had stopped their bisphosphonate. So don't be nervous about doing drug holidays. To me, be nervous about not doing drug holidays because of the atypical femoral fracture risk that absolutely does happen when we are on an antiresorptive for too long. All right, so I've got up here third line and less high risk than our first line. So this, to me, I'm assuming is going to be news to most of you, and I want you to leave here with a change of thought process. We have more and more data that says that order matters in osteoporosis. In other words, when you put somebody, so the way it usually is with insurance companies, right? You need to fail this to then go to this. You need to fail this to then go to this. So what used to happen all the time would put somebody on a bisphosphonate, would put them on Prolia. Oh, they're getting worse. Now let's try to put them on an anabolic. The data is really clear that doing antiresorptive followed by anabolic does not get you near as far as anabolic followed by antiresorptive, okay? So again, think of it this way. 1 + 1, when it's anabolic, then antiresorptive, equals 5, okay? 1 + 1, when it's antiresorptive followed by anabolic, equals 2 or 3. So just know that order does matter when it comes to our anabolics and our antiresorptives. So your severe patients, do everything you can to get them on an on an anabolic, not an antiresorptive at first, okay? If you can't do it because these are really expensive, if you can't do it because of cost and insurance, so be it, but die trying. In other words, do all that you can to get them on that. And so we have 3 anabolics. The longest it's been around is Forteo teriparatide. It now has a generic, which are called biosimilars in this world. It's dramatically cheaper than what it used to be, and it's still crazy expensive. But insurance companies will cover that in certain situations. We do have good head-to-head data there, as I've got up there, where it is superior to our antiresorptives, most specifically in compression fractures of the back. Many of these studies don't go on long enough to show any difference with hip. And then Timolose is its cousin. As I said below, think of it as the same as Forteo, other than it's a little bit better tolerated. So both daily shots, both for 2 years, both anabolic. And then Avinity is our other anabolic. Avinity, you actually often have better luck getting patients on it because Avinity is an office procedure, and many of these are Medicare patients, so it ends up coming out of their Medicare Part B rather than their D. If they have Medicare and a supplemental, it's often free, and so this very expensive medicine is actually free for them when they're appropriately put on there. Avinity, the main thing to be aware of with Avinity, there's a black box warning for stroke and heart risk. One study showed an absolute increased risk. The other subsequent studies have not. Really, to me, the jury's out. But just don't use it in people who've had a recent stroke or heart attack is really where you should fall at this point. And I think I've got that down below, so the frame study, there was no difference. The interesting thing, so you'll see down below, this was a cohort study. So again, not ideal, but 20,000 patients, there was higher cardiovascular risk with the PTH analogs than with Avinity. Again, that was, looking back at things. But even though that black box is there, I don't want you overly freaked out about it, but I still would avoid it in those patients. Questions about anabolics?
Yeah, so for both of the PTH analogs, does the patient need to have a normal PTH? You said it on the terrafertine, but also, so for both of them, would they need a normal PTH before initiation?
And so you said I set it on there. So as a general rule, yes. So going to that, so with both of these, you generally should have a fairly normal PTH prior to starting this. Now, I emphasize fairly normal because it'll depend upon your overall situation. The classic example would be, somebody who has severely low vitamin D and they've got a mildly elevated. You're going to assume, and you're going to recheck, but you're going to assume that that person is probably vitamin D related. I'm not going to necessarily wait for a few months to start that, but it's usually going to be just mildly off. So, but your classic example, and I have probably 10 patients in my practice right now who have mild primary hyperpara, and we're not doing surgery with them because they're doing okay overall clinically. They've got other risk factors that make surgery not ideal. That's not somebody I'm going to start on a PTH analog. So, great question. Other questions on the anabolics? All right. Well, we were a little bit behind, so I'm going to try to wrap us up here shortly. I'm going to skip past that. Other meds, I really don't want to get into these a lot. There's really not a lot of indication. Head-to-head trials, again, this is mostly looking at bisphosphonates and our anabolics, which we already hit. Drug holidays, we really already talked about. All right, so any other osteoporosis questions, and then before I move on to the next phase? Yes, please. No, I just dealt with an orthopedic surgeon the other day who wanted the patient off for 6 months. What I'd actually say to you is data is actually, an up-to-date surgeon would actually share with you opposite data. Now, it applies more to anabolics, but there's more and more back surgeons who are subscribing to bone optimization. In our perfect world, they're sending them to you and saying, will you please get this person on an anabolic and get their bone strengthened prior to me doing back surgery here. But the classic study, even with our anaresorptives, was done on reclass when it was given to hip fracture patients in the hospital. They broke their hip, they're in the hospital, they're getting IV zoledronic acid, and there was no increased risk of bad outcomes with regards to their orthopedic components. Orthopedic surgeons are still caught in this old world where they're scared to death about these bones, and there just is not data to support that. If anything, there's data to say we should be optimizing bones so that they have better surgical outcomes. Other questions about osteoporosis? So really, after any of your anabolics, I would just simply say you want to use an anaresorptive. That's really, on a rare occasion that somebody is beyond severe, multiple fractures, -5 T-score, would I encourage you to consider going Avinity to a PTH analog? Sure. Are you going to be able to do that logistically, financially? Probably not, but so you're really just transitioning. But I'm glad you're bringing this up because I want to emphasize you are wasting thousands of dollars when you start an anabolic and don't get them on an anaresorptive the day that they stop, okay? You, just like we talked about bone loss with Prolia, you get significant bone loss very quickly with your anabolics. And so I tell, the second I start an anabolic, I drill that into my patient's head. I need to see you in a year when this Avinity is done, and we need to start something that day. I need to see you 2 years from now when this Forteo is done. We need to start something that day, and just drill that in. Otherwise, you waste a lot of money as they end up losing that bone. Yes? Yes. And really what I would say there is calcitonin, to me, vertebral fracture, use it for pain. There is some data that it's helpful there. And then on rare occasions, renal disease. It's one of those that is fairly safe in your more severe patients. But talking about renal disease and osteoporosis is a whole nother conversation, because at what point do you get into renal osteodystrophy and no longer have osteoporosis? And that's an hour talk we could do in and of itself. But oops, I'm going the wrong way. All right. Yes.
Are you doing drug holidays in all patients, or are there situations when you would actually recommend it not?
At this point, I would say, so first off, drug holidays, we really should now be in the habit of saying bisphosphonate drug holidays, but I am doing bisphosphonate drug holidays on all patients. Before, in the past, it was kind of like, okay, this person's really high risk. What are my options? Their fracture risk is high. But to me, those patients where I've deemed that they are that high of risk, I'm generally transitioning them to Prolia or something else. Great data support that, of course there's not. But I just don't see a reason to keep somebody on a bisphosphonate for longer than 3 or 5 years, especially when we have other options we can go to. All right, so the number one risk factor for osteoporosis that we didn't mention is being at a family medicine residency for about 30 years. And so we have a couple individuals in this room who I think are at very high risk for osteoporosis. And today we would be amiss if we did not recognize Jonathan Cree and Bill Woodhouse. And so Bill, why don't you come up here first? So round of applause for Bill. So Bill, we have a plaque for you here, 30 years of service at this residency. There is no doubt we would not be who we are today without Jonathan Cree and Bill Woodhouse. So much of what this residency is because of the two of you and the years of service. The other thing we have here, so we have a check here for $12 million. Don't spend it all in one place, Bill. This is approximately the grant funding that has been brought into this program over this 30 years from other people have helped, but very heavily work that Bill Woodhouse has done. And so very large check that we wanted to pass back to you. So there you are. Yes, I will report back to her on that check. Jonathan, come on up. I will. I'm never without words. Thank you, Jonathan. Yes. So what? Part of what that was quick flashbacks. It was super fun. I'm trying to think if anybody else was there. Anyway, super fun. I was able to put Jonathan's name forward this year, as Bill mentioned earlier, as a candidate for the Idaho Academy of Family Physician of the Year, which he was awarded. But as I was taking that picture with him, it reminded me of being in Sun Valley recently with that award, which was very well deserved. And so here are my sources, and we'll move on to better things. So there's a wonderful picture of Bill up there, and got to have one with him cross country skiing. And then we've got Jonathan there showing off for us here a little bit. So a little bit less than 30 years, but man, we definitely feel like we should be rounding up. He's going to be with us a little bit longer. So, all right, and I think we probably need one more round of applause for these amazing individuals.
So next on our agenda, I go to a lot of folk festivals and other music festivals, and a lot of times between the big acts, they'll have what they're called tweeners, which is local acts that are performing for a short period of time between the two other acts while they're getting set up. And so I decided to do some tweeners today and to sample some of our graduates' cases, interesting cases. So I'm going to ask Brad Brofert to come up and present on his interesting case.
I've got some tweeners at home, so it's good to be, correlated with tweeners, and so I will take that. All right, I'll try and be brief. A little nervous to be up here. Didn't realize how big of a gathering this was going to be. So I currently live in Meridian. I was actually born and raised in Boise, but had the distinguished opportunity to come and learn here at the Family Medicine Residency and graduate in 2016, and appreciate everybody that was a key in my training. I see a lot of you out there, and so I wanted to at least start with a thank you. I mainly practice outpatient family medicine without OB. So I had a 15-year-old, and this is actually just in the last year. She actually presented for a well child check at 14, and we were just taking the normal history, and she had mentioned she hadn't had periods, and I said, well, when you turn 15, please come back immediately. And it was in between her well child checks, and I said, if you're still not having periods at 15, we need to do a workup. So she presented at 15 with primary amenorrhea. Her exam revealed very scant hair on legs and pelvic area, no axillary hair growth. Pelvic exam revealed a normal vagina with the cervix present, and the ovaries felt normal. So I got some labs, and I've never done this workup before, so did some reading, double-checked what labs to order. So, checked thyroid. Thyroid was normal. Serum HCG was negative. CMP, CBC normal. Prolactin normal. LH, FSH, and if you look there, they were slightly above the normal ranges. Estradiol was low end of normal, and also got an ultrasound. Ultrasound revealed normal uterus, normal endometrium, normal ovaries. So you want to throw out what they're thinking so far. Okay, so we got pituitary tumor on the differential. What else? It's okay if you don't know. I had to read up myself. So some type of chromosomal abnormality, some type of gonadal dysgenesis. So obviously based off of the LH, FSH, estradiol, I thankfully have access to pediatric endocrinology in Boise, and so I referred on to pediatric endocrinology. Part of that workup is 21 alpha hydroxylase deficiency, aldosterone workup, that was negative. And of course, being an endocrinologist, he did a diabetes workup, which was fine, but it was normal. And then testosterone came back slightly elevated. And then he did a microarray, and her chromosomes came back as 46XY. So the leading diagnosis is gonadal dysgenesis. What I didn't know is that, unfortunately, there's a 33% risk of gonadоblastoma with gonadal dysgenesis. And so she was promptly referred to pediatric urology, who then got her set up, and they did an oophorectomy. The pathology came back on the oophorectomy as gonadоblastoma and germinoma. In the meantime, between her seeing the pediatric urologist and pediatric hematologist oncologist, she also was referred to, and thankfully St. Luke's has a multidisciplinary Essence clinic, and so they help in these specific type of situations. And so she met with them, and she was already plugged into counseling, and so they recommended that she just continue with that private therapist. Also referred to pediatric genetics. So they recommended doing a full genetic testing. Unfortunately, insurance won't cover it. The cost was estimated to be about $1,200. Family has not opted to proceed with going through with this, and the thought of getting this is to try and, obviously find the cause, and then from that we can reduce risk of doing preventative screenings at a more timely manner. So current care, she's also got plugged in with pediatric hematology oncology, and she gets blood drawn every 4 months. Up there, and then also a CT abdomen and pelvis, and then decreasing frequency over the next 5 years. And then she met back with the pediatric endocrinologist. She is choosing to go on estrogen and is currently on estrogen patches and doing well and starting to form more axillary hair and breast development. She's currently playing volleyball, works at a very popular restaurant in town that just opened up, and is enjoying high school. That's my presentation. Oh, yeah.
I'm curious as to how the recent political situation in the state has impacted your care of this patient.
So, definitely have relied on the Essence Clinic. And so, allowing the Essence Clinic to see her and have some of those discussions. Right now, where her phenotype is what she wants to proceed with, and the pediatric endocrinologist is prescribing those estrogen patches. I'm not seeing any current issues, but I will admit it has made me a little nervous, and is definitely a case that I have used in talking with some patients of how I feel. That we need to be very cautious about the laws that we pass that could intervene in the physician-patient relationship. Yeah.
Any other comments or questions? Thank you very much.
Yeah.
That's family medicine. We just see the same old thing every day. Our next speaker is Philip Vandegreen. Dr. Philip Vandegreen is Director of Sports Medicine for ISU Athletics and the Program Director for the Primary Care Sports Medicine Fellowship at Idaho State University Family Medicine Residency Program, brand new fellowship. He graduated from medical school at the University of Iowa, go Hawks, in 2011 after completing a Master of Public Health. He completed a family medicine residency from Palmetto Health Richland at the University of South Carolina and a primary care sports medicine fellowship from the Carolinas Healthcare System in Charlotte, North Carolina. Dr. Vandegreen comes to us from Orange City, Iowa, where he practiced rural family medicine and sports medicine and was team doctor for Northwestern College. As a family and sports medicine doctor, he provides care for a broad spectrum of medical conditions. He has special interests and experience in concussion care, diagnostic musculoskeletal ultrasound, and ultrasound-guided procedures. He enjoys golfing, hiking, skiing, and spending time in the great outdoors with his wife and 3 kids. The whole family loves watching ISU athletic events and anything sports-related. Dr. Vandegreen.
All right, thank you. Yeah, my family, if you go to any events over at Reed, especially during the winter, you'll see my kids roaming the halls like they own the place. And don't argue with them because they think they do. Thanks, Bill, for that introduction. Phil Vandegreen here. I'm going to be talking about sport-related concussion. No disclosures. I would like to recognize the Idaho Frontiers and Family Medicine Project as this presentation is a part of that, and that grant has made this possible. Goals and objectives today. First, I'm going to say I was thinking I actually had 45 minutes, and so first I'm actively thinking about things that I can sort of brush to the side, but I'll try to do my best. I'm going to go over the current definition of sport-related concussion. There was a 2022 actually consensus update. Renee, it's my fault. I'm not. I promise. Discuss the current understanding of the pathophysiology. Recognize clinical history. I mean, I want to try to keep most of this clinical. But talk about red flags that would maybe necessitate more urgent or further access or evaluation at an ER. How to manage it, though, on the sideline, in the office. Talk about second impact syndrome. Talk about the physical exam and some of the key tools that really are pretty useful, which is the SCAT and also the SCOAT in the outpatient setting. Talk about return to learn, return to play, and talk about management in regard to different subtypes of a concussion, and just talk about laws and legislation, which is the most boring part, which will probably get cut. So, anyway, first of all, and sorry there were some of the residents, they've seen some of this before, but it's all right. Is this going to work? Probably not. Well, that's perfect, because there's my first cut right there. All right, so that was going to be a video of Tua Tagovailoa, which I always have to ask my son how to say, so I always just call him Tua. Can anybody sort of tell me what happened? What was I going to show you?
His head bouncing off the turf.
During a game, during a game, I can't remember who it was. I think it was actually the Bengals. He gets tackled, he gets thrown to the ground, head slams. He kind of gets up, but stumbles a bit, and it's great. It's all caught on camera. The clip I have is actually like from the NFL Network or whatever. His lineman's kind of talking to him, walking, and all of a sudden you see him just do this, and he almost go down. So they take him for evaluation, and what do you think happened? He got put back in later that game because they were down. I don't actually know if they were, but he comes back in. They say he was cleared, and one of their neurocognitive experts, said he was cleared. That fall, he hurt his ankle too. Don't worry, too is good. Kind of, atypical. They actually had a Thursday, so that was a Sunday game. He comes back in because they have a Thursday game. And usually, hopefully, maybe you get back for Sunday. So it's very important he didn't have a concussion. Thursday, got another hit, and that one was bad. It was a hit. He postures. He's out. He's carted off the field on a stretcher, taken to the hospital. The Dolphins neurocognitive expert was fired later that day and said, he did have a concussion. The video is much better. Sorry about that. So this definition is from the most updated 2022 Amsterdam Concussion Conference. And Jonathan, okay, good. You noted that it was, I could see you smiling because it was in Amsterdam, and I thought you'd appreciate that the Dutchman gets to bring that up. But a sports-related concussion is a traumatic brain injury caused by a direct blow to the head, neck, or body. Is interesting to note, resulting in an impulsive force being transmitted to the brain that occurs in sports and exercise-related activities. It initiates a neurotransmitter metabolic cascade with possible axonal injury, blood flow change, and inflammation that affects the brain. Signs and symptoms can be presented immediately. It could evolve over minutes, hours, even a day, I've seen. But commonly, the neuropathology, clinically, it will resolve within days, but it can be prolonged. I know this is a long definition, but I wanted to take it straight from the Dutchman's mouth. It's also noted that there's no abnormality seen on standard structural neuroimaging studies. I bring that up because how many times have you guys been in ERs or wherever you are, say, I wanted to bring him in just to make sure he doesn't have a concussion, right? Their expectation, I think, was how I read it, is that they need a CT, they need an MRI to do that. You don't. I fight the urge to be myself and say something cynical like, well, I can tell you right now that it is, whatever. But I just want to note that MRI, CT, that is not a part of the diagnosis. Sport-related concussion results in a broad range of symptoms, basically. Often the symptom signs of a concussion cannot, let me back up. The clinical symptoms and signs of concussion cannot be explained by other causes of mental influence that could happen along with it, or other sort of nerve injuries, spinal injuries, and again, other comorbidities, psychological, physical, that could be co-occurring. So very briefly, it's a trauma with some sort of symptoms that I'll show you in a bit, and with or without loss of consciousness. Now, I feel like the with or without loss of consciousness, to me, it's kind of how I've been raised, but in clinical practice. But I still run into it a lot that is not the general understanding. Somebody says, well, they just got their bell rung. If somebody ever says they got their bell rung, they have a concussion. That just means they didn't pass out, maybe, or whatever. But that is, so it's important to note that it doesn't, if it's downplayed because they didn't lose consciousness, that it doesn't mean anything. There's also not a grading system. So some of the previous diagnostic algorithms did have grading systems. That is no more. It is a concussion or it is not a concussion. There's no mild, there's no moderate, it's a concussion or not. Actually, one of the best parts of this presentation for me too is often to go over some of the pictures that I get. And I'm not entirely sure that he may have ended up in the penalty box for that, but the pathophysiology of a concussion is complex, and each sort of statement you'll read will have some sort of brief statement or something to the effect of it involves a complicated or multi-system approach to the pathology, which is true. So it makes going through the pathology a little bit tough. I use this is actually kind of an older slide, but I like it because it goes through some of what we know about the pathophysiology of a concussion. There's still a lot that is being researched. There's biomarkers that are under research, but we still don't know. They're still not meaningful. They're research tools, functional MRIs that will be able to show us some stuff. But again, they're not for clinical practice. But so you get, if you look at this, there's an initial hit, there's an injury, which on a very gross scale, physical scale, has some axonal damage, just that pound and shift. Okay, then you go the other way, that also will just create, that's stress to the body. So you get some inflammation, you get inflammatory cells, which are going to cause cellular damage and cell death, along with trying to clean up whatever debris is there. That stress, that hit also will cause the neurons the membranes, the axis to be very excitable, neuroexciticity, which releases neurotransmitters and chemicals that just, it's a rave, right? The next day is going to be terrible at a rave. I just want to say I've never done that, but it popped in my head as maybe it could be applicable. I swear, I'll take a drug test right now. But some of those things can cause some apoptosis. It also affects your mitochondria, which is very important for reducing oxidative stress, which now your body has just ramped up into. And then way down the corner, I don't like that that's down the corner because that's actually that hypermetabolic state is what your body is in. It's actually a really pretty central, important part of what causes a lot of the different effects of a concussion. Because your body is stressed, it has all this oxidative injury that is trying to neutralize. It's using all your glucose and ATP for that, all right? So people get tired putting their clothes on. I tell people, you're going to be tired doing normal daily things that you'd never even thought you had to think about. And it's because their body is in a very hypermetabolic state, which, since it's all used up, then they go into this hypometabolic state where they're in this also survival mode, where they're trying to conserve energy. All of that, your body's stressed. This is why we take you out, because now your body is more susceptible to another injury. All right. So in the end, it's much easier to say it's a complex, multi-system pathophysiologic problem. But sometimes it's fun to go through the map. The signs and symptoms that you're looking for, so you got a hit. Now, what are these signs and symptoms you're looking for? Here's the list, and this list is straight from the SCAT-6 that you can use in your clinical practice. And all of these, these have all been researched, extensively validated. Some of the ones, though, that really I think will pop out, headaches and pressure in the head, I'd say is one of those are most common. But as vague as it is, don't feel right is also just one of the common ones. And it actually, sometimes that translates well to kids because they just don't feel right. Sometimes I talk about that with mental fog, brain fog. Sensitivity to light and noise are very, very common, especially sunlight. Sunlight is more bothersome often. But also then I've had people that it's just different types of fluorescent light. And then the difficulty concentrating, fatigue, those are very common. I also will point out some of this emotional ability, though, is not always the most common, but it's surprising to see. I've been on the sidelines with some of the biggest men who are very typically masculine, just weeping for they don't know why. They're super irritable and they can't be consoled. I think you, Brandon, had mentioned that once before, but you're like, whoa, what's going on?
It's obviously a change from what they normally are, and I've seen it multiple times. I mean, they're the most emotional person crying at the drop of a hat, and that's not them normally.
Right, yeah. Okay. So on the on-field sideline assessment, at first it's your typical trauma stuff. Fortunately, that's often not, it's actually often not the main thing that you got to be worried about everybody's C-spine on the field. But that is obviously the first priority is your ABCs, your airway, breathing, circulation, C-spine precautions, which have evolved, and we can often probably, if there's concern, you can clear them on the field. You want to note their level of consciousness or what you suspect their level of consciousness was. So a lot of times it's a brief loss of consciousness, less than 30 seconds or so. The best ones I have an athlete that I joke with that I know he was passed out. Every time has come to me and said, just got the wind knocked out of me. So that's what I always ask him first, just get the wind knocked out. Yeah, I'm good. I'm good. Sometimes I'm surprised at how well they can really hide it. It's a skill. It's a skill. Prolonged loss would be more than 60 seconds. I think that's semantics because 30 seconds can seem like 2 years. When I've told maybe you guys about my residency oh no moment with RPF of 10. And that was where a kid got hit, came to the sideline, he was fine for a while, then he passed out. I don't know how long he was out. It seemed like a day to me. But we went to the ER, and nobody's ever going to fault you for a loss of consciousness in a kid that you take to the ER. I just want to note that if they do pass out and they seem okay, they're definitely not going in, but they may not have to go to the ER. On the sideline right away, first of all, there's a tool called the concussion recognition tool. And it's actually meant not for physicians, but it is quite useful as a quick guide to look at the signs and symptoms and then say, oh, is this something I need to go further with, in which I take my other tool, the SCAT, out, which I'll get to. But otherwise, it's your main sort of neural stuff, your cranial nerves, pupillary dilation, balance coordination, motor strength, some cognitive function, serial 7s or 3s, or I'll ask them who scored last or what's the score. Hopefully, so they can't see the scoreboard. Like I said, I got you can also use some of those concussion recognition tools. But this is a clinical diagnosis, all right? So when you have those symptoms after a mechanism, that is likely a concussion. Now, there may be other factors that you need to tease out, and that's probably going to not happen on the sideline. I would advise that it doesn't. If you're suspicious, hold them out, and let's figure that out tomorrow or in the office, because it's most likely a concussion. But there's also these other tools, which I don't want to downplay because I find them very helpful, and they are being up. I mean, these were updated in 2022, published in June of 23, and they're starting to really build their sort of library or their validity across all ages. So at first, I mean, the SCAT was really just reliable above the age of 12. Well, they've got a child SCAT that is 5 to 12 now. Younger than that, it is still, we don't have a great tool. There's a large push to look at and work on concussion recognition tools in para athletes. There's a whole bunch of other things to think about when you're talking about balance or whatever. So I was going to click on these. I'm not going to. I would like to, because evidently I can't bring them up anyway. But I have the links to these. You can also just, if you Google either SCAT6, child SCAT6, or most updated concussion recognition tools, whatever, these will all come up, all right, as well as the outpatient office ones that I'll show you. And I have adapted them in the past to go really quick. The newest ones is actually, it's a pretty extensive, or it's pretty full. It actually walks you right through what to do with it. But familiarize yourself with it first, because you want to it's not something I would say just pull out and quick do on the fly. You have to go through the steps and know what you're getting. And honestly, going through one of those could probably be its own lecture. I do want to stop there. Does anybody have questions about that? Great, good. Also, there's, again, no imaging needed for diagnosis. Okay, you don't need an MRI, you don't need a CT. The reason that you go to the ER is if you are concerned about a neural red flag, or you are looking for you're concerned about a focal neurologic deficit, which, so some of these are the things you're going to be looking at. Like I said, loss of consciousness, vomiting, recurrent vomiting. I've seen people vomit often or with a concussion, but if they vomit twice, then the RPF goes up a little bit. The irritability, fatigue, the increasing confusion, or rapidly worsening headache, right? It's, without saying it's the worst headache of my life, it is a bad headache and it's getting worse. Those would be good reasons to go. So, has anybody heard of either, I haven't done that yet, Impact, ANAM, Axon, or C3 Logics? A lot of our school districts, I would say most of the school districts employ these computer-based neurocognitive tests, and they're helpful, but they are not standalone. It's important to know that. Do you have a question, Brandon? No, okay. You're just breathing. Good, all right. So in the statement, they explicitly say that the results of a computerized neurocognitive test should be interpreted in the context of the broader clinical findings and not used in isolation to inform management or diagnostic decisions. So just know that. They are very helpful, and especially if you have a baseline, sometimes it's nice to look back, but they've been validated mostly, or not mostly, they've been validated or shown to be the best in the first 48, maybe 72 hours to say concussion or not. Past that, the reliability isn't as good. But it is a good clinical tool, even 10 days out or whatever, to say, well, in conjunction with you saying, I'm a little more tired, which is hard to quantify, this number is a little bit low. Let's hold the brakes. Let's pull back a bit. So they are helpful. As far as management, let's move on to management. The management really, so I have here that we need to focus more on sort of the subtypes of concussion, which that's what we're doing. That's what in the new statement also proposed that, and we're heading that direction. Which the way, we thought about, I think, concussions before, sometimes it's hard to not, it's a concussion and that's it. So we treat concussions like a concussion. So you got a concussion, you do this, this, and this. But it's not like that, or that's not the best practice, because focusing on the specific subtypes, which is basically just the more prominent symptoms, is going to help you get better quicker, and not miss certain things that I think a lot of times, if we don't address, people do get prolonged symptoms, and it's very discouraging to people. And I've seen a lot of people that are they're ready to accept that this is the new them. And I try to tell them, hey, you're gonna get past this, all right? But it may take a bit. But this is not you. You do not have a post-concussive syndrome. You just have some prolonged symptoms. And some of the anxiety or mood, the vestibular, the oculomotor, the cognitive, and post-traumatic migraine are some of the subtypes that we've grouped some of this into. So immediately you need to get them out of there. Again, and it's sometimes hard, not fun, to tell a coach or somebody that this person needs to come out. All right, and that's why I put this quoted in here to show you how many qualifiers there are. From the most recent consensus statement, it says remove if there is suspicion of a possible concussion. All right, it's not saying if you are a neurocognitive expert and you think actually they're not doing that good anyway. If you are and you absolutely know there's a concussion, then you should probably take them out. It's saying if you are a healthcare provider, actually this also goes for coaches, refs, whatever, they're also on the hook. If you think that there could be a concussion, take them out. And so signs to help you with that, things that really give you maybe a leg to stand on with them, is loss of consciousness, actual or suspected, seizure, I don't think people will argue, but tonic posturing, shouldn't argue. Ataxia, people did argue. Poor balance, people probably will argue. Confusion, they'll argue. Behavioral changes, they're going to argue. Amnesia, it's hard to argue, maybe, but they don't want to hear that. So my point is, stand strong, right? Just tell them. If you are covering that and you think you're the medical professional and you think that there might be a concussion, that person is out. The other thing is, how many people have gone to their kids' games? If you have kids. And have you ever been called out of the stands because you're a doctor? Yeah. You may accidentally, I'll give you freedom right now. If you want to just shrink down, that's fine, you can shrink. But if you're in a small enough town, there was no hiding, you will be known as the doctor, and so they'll be asking you to hey, what do we do? All right, so Still go to your kids' games, though. I don't want to scare you. You guys should go to games. You guys should go to your kids' games. I think that's important. Don't hear me say that. Also important, no same-day return to play. The only way, Tua actually did go through that. The only way you can do a same-day return to play is if you have evaluation acutely by an experienced healthcare provider with a multimodal assessment who determines that they can play. And the multimodal assessment is something like a SCAT that I was telling you about, those links, or the SCAT form. Rest and exercise. This slide used to be brief. Sorry, guys, I made it longer. But it used to be brief and said, the mainstay of concussion treatment is rest. Well, that's not true anymore. I guess that's a statement of reality. I guess now we can debate about pontificate and philosophize. But anyway, the reality always was that a concussion, that rest, strict rest, cocooning, what we would call it, is not the best thing, right? So it's not beneficial, and actually it could be harmful. Relative rest can be beneficial in the first 24 to 48 hours. Relative rest is your ADLs, just normal daily life, reduced screen time, which is vague. They don't really elucidate on that, but reduced screen time. They could also do some light intensity physical activity, even during the initial 24 to 48 hours. And so they talk about that as walking or some light activity that does not increase your symptoms by more than 1 or 2 points on the whatever scale you use. Specifically, they're looking at a concussion assessment scale, okay, by 1 or 2 points, and then doesn't go away after an hour, okay? So a lot of people do okay with that, though. A lot of people can go for a walk for 30 minutes, whatever, walk their dog, that sort of rate, and the symptoms will go away after an hour if it goes up by 1 or 2. If it goes up to more severe, then you got to back down. And then along those lines, also just early return to more intense physical activity, and there's something, this is probably to be done more with like an athletic trainer or somebody who can watch them better, and you're actually getting your heart rate about 50 to 70% of max, and then you're having them maintain that and not letting their symptoms go above a 1 or a 2 and persist for more than an hour. And so that allows people to maybe start to get to do some more cardio or something more intense while they're being watched that way. But the point is, we're really trying to push these people, not cocoon them, right? And the same thing goes with sort of school and screen time. So I used to tell everybody just get rid of any screen or whatever. But within the first 48 hours, within the first 40 hours of that might be warranted reducing that, but may not be effective after that. And so studies show that actually there's better effect. Kids are getting, if they start to get back to learning, they start to get back to their education sooner. And there's a lot of other factors at play. There's social factors, mood factors, all of this. And so if they can, we want to start to, after the first 48 hours, reintroduce some of that normal, screen time, because all homework, I think, is on the screen now, and some schoolwork. So this is now after they've had a concussion, and you're probably going to see them in the office. They have this tool called these SCOTs, Sports Concussion Office Assessment Tool. And again, there's links in here. There's also links at the end, but you can find these online. I would recommend getting this in your office if you're going to see concussions. It really it breaks it down and brings you through it. But the thing is, these haven't totally been, the SCOTE 6, it's the newest of them, and it's for the office, so it's intended for 3 to 30 days, or 3 days to 4 weeks of management. And so it hasn't been out long enough to say that it's totally been validated. They don't give you scores, but like to say, oh, this is a concussion, or they're getting better, or whatever. And that's partly intentional because it's a clinical diagnosis. They say none of these things should stand alone. You need to be a doctor and make that decision along with these tools. So anyway, those are there. Again, I use these, and it's the trends I'm looking at. You're looking at the trends. There is a lot of evidence that, again, physical activity can be beneficial. And also, if there is if athletes have a lot of neck pain, headaches, dizziness, balance problems, then some concussion rehab or cervical vestibular rehab can be really helpful. And I also would add that doing some counseling or something could also be very helpful if depression, anxiety is a strong component, which it can be. And as I noted, I think earlier, that we don't say post-concussion syndrome anymore because everybody will know you're not cool. The cool thing to say is persisting symptoms. But there is a little bit of reason for that, is that post-concussion syndrome labels somebody, and I've had people that feel like, oh great, now this is this thing I got this post-concussion syndrome, this disease I'm going to have. Whereas if you say it's persisting symptoms of a concussion, that semantically seems a little more palatable. As far as more sort of lifestyle things, I tell people to stay really well hydrated, eat lots of carbs. I would change this to say try to stick to healthy carbs. Dietary fiber, there's times your body crashes and you need those quick, simple sugars to get your energy back up because your body is in a hypermetabolic state. And that's fine. Your body is going through all these energy resources. And then avoiding certain stimulus. As I said, I have on the very bottom possibly computer work because that one kind of fell off. That might be okay. But it's more the really rambunctious visual stimuli. I don't know how many more Fast and Furiouses they're going to make, but I'm sure they'll continue to make those to bother concussions. Those are the kind of movies you'd want to avoid. Texting, I always do note, though, because if you think about texting, you're looking at a smaller screen with a bright light coming back. So you're focusing and you're having that visual stimulus. So that's often a more problematic one. There's some pharmacotherapies, and the fish oil is one that we've done. I've done myself. I've gone back and forth with it, looking at things. Right now, I'm kind of throwing my hands up in the air. It doesn't hurt. There's not a strong advocation or there's not strong evidence for it. However, some of the earlier mice studies actually did show some benefit, but the benefit was more if they were taking it prior to a concussion. So preventing brain injury could be more beneficial for long-term fish oil use. But again, there's a lot of health benefits, and it does provide oxidative or neutralizes oxidative stress. All the other sort of pharmaceutical things are pointing more at the I almost was uncool. Persistent symptoms after a concussion. And these things can be really helpful, especially, so sometimes I'm dealing with these more with kids that are going past this 4 weeks, or industry athletes, people who have to get back to work or they need to get back to the office. So amantadine is one of the first ones I'll use for actually focus or cognition. Methylphenidate maybe, sleep, melatonin, SSRIs or SNRIs if there's a lot of anxiety. But just target the most prominent symptom. When you're getting a student back as well, the thing you want this table is about return to sport. This is important. The first thing they need to do is get back to return to learn. Before they can go to return to sport, they need to go and return to learn. And so this is from, I think, the paper before this, but they initially are going to have 48 hours where they may be a little bit inside, or they may be reducing their cognitive load. But again, if you can then get them back, and then the people that you try to get back after 24, 48 hours to school, then they start to have problems. Then you use something like this, a return to learn protocol, where it's a more stepwise approach. And that's in this table you guys can use. This return to play protocol is very similar. There's a couple differences in the fact, one of the biggest differences I'll note is that once you get to the later stages, first before you go into stages 4 through 6, an athlete should get clearance from a healthcare provider before going into the more team-specific things. The other thing is that if they go past that in stages 4, 5, and 6, and they do have worsening symptoms, they actually have to go back to step 3 once symptoms clear. Whereas before you could have gone from 5 to 4, well, now you got to go 5 to 3. Again, those are in the papers. I have these printed off, and actually they're in the SCOTE. They outline all of that, so I would recommend using that. Here's some management strategies for return to learn if kids are really having a hard time getting back to just getting cognitive tasks, so you can give them accommodations for testing or delayed testing or what have you. There's no set number for concussions that disqualifies you, okay? There's not a number. It's a large discussion, it's a long discussion, and there's a lot of factors that may go into that, such as number. How long is it taking now to get over these? Are you a different person? Do you have behavioral changes? Are there any deficits? And there are some things that will modify sort of that, how long it takes to get over. And here's a list of those modifiers. I noticed that the frequency that they've had concussions, and then sort of, so if they've had multiple concussions close together, and if they've had repeated concussions, and their threshold for concussion is lower, those people will tend to have more prolonged outcome. Second impact syndrome is what we're trying to avoid. This is rare, but it's what we need to avoid. And basically, I think of it as flash pulmonary edema, but of the brain, okay? So there's a first hit. That causes your autonomic nervous system to not be quite right, so you get a nice little tap. It's not a hit. It's not a large hit. This is why we need to identify them and get them out. Because the second hit is a little bit of a rub to the jaw or whatever, and it's nearly universally fatal, okay? And most certainly universally devastating. These people will never be the same. They will be disabled if they live, which most of them don't. Legislation, it's boring. There's some legislation. Here's some here's some tools for you, and also some education materials that you can use to hand out to your patients. All right, thank you. Sorry. I'd say any questions, but I know I'm out of time.
So we have one more tweener presentation to go, but before I do, I want to give thanks. A lot of folks really came together to make this possible today and to support this program. Liz Woodruff at the Idaho Academy of Family Physicians helped us with CME credit. For those that want to seek 2 hours of CME credit, make sure you turn in your evaluation form and we'll give you a certificate for up to 2 hours of participation. It's over here at the desk. I want to thank the folks here at the ICCU Bengal Alumni Center staff for helping us get everything set up. I want to thank Chartwells for the food service. I want to really thank the help of the ISU Marketing and Communications program. Leanne Waldron was with us earlier, but they helped us produce this 30th anniversary commemorative book that's out there on our out on the desk, and we'll be having, it's still a little bit in evolution, we'll be having it on our website for access at if you want to look at that on down the line or use one of the copies that's there. And then finally, and I think most of all, is our administrative staff at the Department of Family Medicine, Renee Thompson, Caitlin Oots, Casey Tennant, Greg Harding. These folks really went out of their way to make all this happen today, and I'd like to give them a round of applause. So our last speaker is another tweener, and it's Travis Nielsen will be presenting.
All right, I'll be brief because I know everybody wants some appetizers. Yeah, I think most of you know me. I'm Travis Nielsen, graduated in class of 2011. Started at Intermountain after residency, and about a year later, Dr. Cree asked if I could come back and help, and so I've been splitting my time ever since then, and I've really enjoyed it. So I'm going to talk about a 41-year-old with a headache. Dr. Cree suggested that maybe I pick this case because I think it's an interesting one. So as I talk, just kind of think to yourselves what you might do as you get the information. So I have a 41-year-old male with 10 days of a right-sided headache. Points kind of the right side of his cheek, head, kind of behind the eye and cheek. He had been given some Augmentin for maybe a sinus infection, but actually seems to be getting worse instead of better. Tried some usual over-the-counter things, worse in the morning. The day that he comes to see in the clinic, it got really severe that night. Really couldn't sleep, and said that's just getting pretty intolerable. Really pretty boring past medical history, some mild migraines, usually is treated with over-the-counter medicines and trigger avoidance. This seems to be separate from that. No medicines, no substance use. Blood pressure and heart rate are elevated, which is not usual. It's usually quite normal. You think that maybe you see a little bit of ptosis in the right eye, and the chart says sluggish lateral gaze of the right eye. Interestingly enough, there's allodynia, basically tenderness to light touch to the right side of the scalp, which is a little bit weird. So you do some labs. You look in your sample cabinet, and you have this reval. It's a migraine med I haven't really used before, but it's supposed to be safe for migraines. And you're able to pull some strings and do a same-day MRI, and it's read as totally normal brain, normal blood vessels, no sinus problems. And so you end up starting him on some amitriptyline. The medicine you give in the office seems to decrease the pain by about 50%. Amitriptyline seems to decrease the pain, and he's able to return to work. But the pain never really goes away. Then a few days later, he starts having some pulsatile tinnitus in his right ear that's more noticeable with physical activity. And so then you end up getting a CTA of the head and neck. And it shows a carotid artery dissection with a thrombus. And the clot is kind of wedged underneath the intimal layer there. And upon further review, it was there at the initial MRI. So just a little bit about this, because it's probably not something that you see every day. These are some of the symptoms that you can have here. You can see some Horner syndrome because it can affect the sympathetic ganglion along the internal carotid artery. CVA or TIA happens in about 80% of people. More rarely, you can have a subarachnoid hemorrhage, and that's usually if it's the internal or intracranial part of the carotid artery. Fairly rare, about 1 in 120,000 people. You really can divide it into two categories, either traumatic or non-traumatic. Traumatic meaning, roller coaster, MVA, some sort of rapid acceleration, deceleration. Or if not traumatic, then you want to be thinking some of these other things, connective tissue disorder, stimulants, fibromuscular dysplasia, things like that. There has been some association with recent COVID infections as well. Treatment's debatable, depending on which academic center you go to. If it's extracranial, usually it's anticoagulation. If it's intracranial, usually it's antiplatelet. Rarely you will do some endovascular stenting if there's current TIA or stroke symptoms, or upon serial imaging the dissection is extending, or if the symptoms just aren't improving. The reason why I think this is interesting is primary care. We're on the front lines for everything. We're the ones that are first seen, and so we have to keep our minds open to what it might be, and I think that's what we get a great training at this residency. And also is interesting because the patient was me, so. So anyways, thank you, everybody.
This concludes our CME program for this afternoon. I thank you all for attending, and what will happen